Good morning. Today I will be talking about chronic laryngitis. What is chronic laryngitis? It is the chronic inflammatory changes in the larynx as a result of persistent irritation, infection due to single or multiple sources affecting the larynx, leading to permanent mucosal changes like glandular hypertrophy, keratosis, and subepithelial hemorrhage. What is the etiology? So, infections of paranasal sinuses, oropharynx, and lungs, occupational factors, smoking, alcohol, chronic cough, mouth breathing, repeated throat clearing, vocal abuse, GERD, gastroesophageal reflux disease, or LPR, laryngopharyngeal reflux, and inadequate hydration. These are some of the factors which contribute to chronic laryngitis. Let us have a look at the pathogenesis. On exposure to these chronic irritants, what happens? The larynx mucosa, it may have irritation, which may be localized or diffused and cause inflammatory changes, which are hyperemia, vasodilatation, submucosal hemorrhage, interstitial edema, exudates, infiltration of mononuclear cells, hyperplasia of epithelium, pseudostratified ciliated columnar epithelium changes to squamous type, invasion of fibroblast, subepithelial hyalinization, thickening and deforming, squamous metaplasia, keratosis, hyperkinetic voice or vocal abuse resulting into vocal nodule, vocal polyp, or contact ulcers. The chronic laryngitis can be classified as non-specific, which is subdivided as hyperemic, hyperplastic, hemorrhagic, vocal nodule, vocal polyp. Then there are few specific conditions of chronic laryngitis, that is tubercular, syphilis, leprosy, scleroderma, and laryngitis sicca. Let us first talk about chronic diffuse laryngitis. These patients present with hoarseness of voice, raw sensation in throat, vocal fatigue, aphonia, pain on phonation, pain on swallowing, and repeated throat clearing. When you examine these patients, we see that the true vocal cord loses its pearly white appearance and become pink or dull red. There may be engorged blood vessels on the surface of the vocal cord. Vocal cord margins become rounded and the sharpness in the margins is lost due to edema. Sticky mucus secretions may be seen on the vocal cord. Polypoidal changes in the true and false vocal cords. Heaping of epithelium with keratosis and submucosal hemorrhages on the vocal cord. This is how we differentiate. This is a picture of acute laryngitis. You can see it is a generalized edema of the larynx, hyperemia, vasodilatation. But in chronic laryngitis, the edema, vasodilatation is restricted to the vocal cords only. The investigations which need to be done are telelaryngoscopy, flexible laryngoscopy, or stroboscopy, X-ray chest, X-ray PNS, nasal endoscopy, fiber optic esophagoscopy, microlaryngoscopy, toluidine blue staining, and biopsy. Treatment is by elimination of irritants, control of infection, treat the allergy, treat GERD, take voice rest, voice training, humidification, steroids as topical inhalers, mucolytics, fluids, vocal hygiene. If the medical line of treatment does not work, surgery may be required, microlaryngeal surgery, stripping of vocal cords. Vocal nodule or singer's nodule is a common condition. It is common in people with high pitched voice caused by excessive vibration, excessive vibration at the junction of anterior one third and posterior two third of the vocal cord, submucosal edema, hemorrhage, inflammatory edema which collects and gets organized, hyalinization and fibrosis. Now these conditions of vocal nodule can be managed medically by voice training, avoidance of vocal abuse, voice therapy. But if it does not respond, then you have to do a surgical excision by microlaryngeal surgery. So this is a classical picture of vocal nodule, bilateral vocal nodule at the junction of anterior one third and posterior two third. These are the contact points where on phonation there is maximum vibration and these result into vocal nodule formation. Another condition is vocal cord polyp. This is disorder of vocal abuse seen in professional voice users characterized by hoarseness and presence of sessile or pedunculated mass arising from one of the vocal cord. The most common benign lesion of larynx confined to the middle of vocal cord. Etiology is similar to vocal nodule. Sometimes it follows acute respiratory infection where there is long lasting severe cough. Single episode of vocal strain may cause a vocal polyp. These patients present with hoarseness of voice, sticky sensation in throat, and repeated throat clearing. On laryngoscopy, you see a solitary polypodal lesion on one vocal cord, which is better visualized on phonation. Now you can appreciate it is in the polyp on this left vocal cord. It is in the mid area and which is visible on inspiration. This is same picture. This I have just kept to make you understand how the indirect laryngoscopy picture and the direct laryngoscopy picture differs. Now this picture is by indirect laryngoscopy and you see a polyp on this side. Okay, this is the left cord. This is because this is a mirror image. But when you do a direct laryngoscopy, you are doing it while you sit behind the head of the patient and your left is patient's left. So this is how on direct laryngoscopy a left vocal cord polyp will appear and this is a picture of the same patient in indirect laryngoscopy. Again, it is on the left vocal cord, but because of the mirror image, its appearance is reversed. Another condition, tubercular laryngitis. Now, tubercular laryngitis, it is not a primary condition of larynx. It is a secondary condition due to direct implantation of the sputum of tubercle bacillus on the laryngeal area. Now, the posterior part of the larynx is mostly involved, or the epiglottis may be involved. Now, there are four stages in tubercular laryngitis: catarrhal stage, granulomatous stage, ulcerative stage, and cicatrization stage. Now, when you do a laryngoscopy of this tubercular laryngitis, you can see the classical turban-shaped epiglottis. There is bulky and edematous arytenoids. You can see the mouse-nibbled appearance of the vocal cord, and there is interarytenoid mammillations and fibrosis. Clinical features of tubercular laryngitis are hoarseness of voice, odynophagia. Now, this, apart from other laryngitis, there is pain, pain in swallowing. There is odynophagia, dysphagia, cough. There will be history of weight loss. Vocal cord, as we have seen, it has got hyperemic, mouse nibbled appearance on the cord, mammillated swellings of the arytenoid and interarytenoid area, turban shaped epiglottis. The investigations which need to be done are X-ray chest, sputum, three consecutive sputum examinations to identify the AFB, cultural sensitivity, Montague's test, and a direct laryngoscopic biopsy may be done. Once the diagnosis is established, you have to treat the primary disease, which may be a pulmonary tuberculosis, and the laryngitis will automatically be taken care of. You have to give the anti-cox therapy. Another less common condition, syphilitic laryngitis. The causative organism is Treponema pallidum. It may be congenital or it can be acquired. In congenital, it can be in early form or late form. When it is in the early form, it is within first few months of the birth. There is laryngeal edema, infantile snuffles, there is constant watering from the nose, and there is hepatosplenomegaly. In congenital late form, it manifests at the age of 2 to 10 years. There may be laryngeal ulceration, stenosis, stridor, interstitial keratitis, nerve deafness, frontal bossing, Hutchinson's tooth, saddle nose, and cluttered joints. When we talk about acquired syphilis, it presents with hoarseness of voice, stridor, and dyspnea. It has got four stages: infiltration stage, granulomatous stage, ulcerative stage, and cicatrization stage. The diagnosis is by dark field microscopy, VDRL test, rapid plasma reagent test, Wassermann reaction test, TPI, and TPHA. Treatment will be procaine penicillin for 10 days or doxycycline 300 milligrams for 21 days, or you can give benzathine penicillin 1.8 grams 4 ml single dose intramuscular. Another condition which is secondary to the nasal condition, scleroma of the larynx. The causative organism is Klebsiella rhinoscleromatis. So this disease spreads from nose and it goes down into larynx, trachea, and bronchus. The patient presents with hoarseness, cough, and progressive dyspnea. There is swelling of subglottis. The treatment of the diagnosis will be biopsy of the lesion from the nose or the larynx. Tetracycline is the treatment of choice. Alternatively, ciprofloxacin and rifampicin may also be used effectively. Steroids may be required to reduce the edema in cases of dyspnea and respiratory distress. In extensive scleroma of the larynx, tracheostomy may be required. Laryngitis sicca or atrophic laryngitis is another condition. Again, it is associated with atrophic laryngitis. So there is atrophy of the laryngeal mucosa and crusting as in cases of atrophic laryngitis. Patient presents with hoarseness of voice, cough, dyspnea, foul smelling discharge, foul smelling crust, and bleeding from the crust. Treatment would be humidification, laryngeal spray with glycine or oil of pine, expectorants containing ammonium chloride, iodides to loosen the crust. Edema glottidis. It may be an emergency. This condition is an emergency. Etiology is infections, trauma, sometimes iatrogenic, allergy, radiations, or systemic diseases. The patient presents with severe respiratory distress and inspiratory stridor. On examination, it can be confirmed through IL indirect laryngoscopy. There is severe edema of the larynx, which is of acute onset. Management, you have to identify the cause. If it is a drug allergy, you have to withdraw the drugs. If it is to neoplasm, it has to be addressed. Infection has to be treated, and you need to give steroids and adrenaline 1 in 1000, 0.3 to 0.5 ml intramuscular and repeated in 15 minutes in cases of angioneurotic edema. Sometimes, if the distress is not responding to steroids and adrenaline, laryngeal intratracheal intubation or tracheostomy may be required. Rinke's edema is a edema in the submucosal space along the length of true vocal cord from superior arcuate line to inferior arcuate line. Due to the loose attachment of mucosa to the vocal ligaments, blood vessels and lymphatics are almost absent in Rinke's space, which prevents early spread of cancer. Rinke's edema is a fusiform swelling. You can appreciate this swelling in the vocal cord due to edema in the Rinke space. Thank you.